One of the most common types of healthcare-acquired infections is a bloodstream infection from a central venous catheter, also known as the central line. Remember that a central catheter is inserted into one of the great vessels of the body and terminates near the heart. It is usually inserted into the subclavian vein, but can also be inserted into the jugular vein, or as in the neonate, the umbilical vein or artery. The catheter is used for infusion of drugs such as chemotherapeutic agents, or for the withdrawal of blood or hemodynamic monitoring. In order for a bloodstream infection to be classified as a CLABSI for surveillance purposes, it must meet both of the following two criteria. It must be confirmed by lab testing that the catheter is the source of the infection, and second, the catheter must have been in place for the 2 days prior to the onset of infection. It is estimated that one CLABSI costs $6,000 to $30,000 to treat. Despite the significant cost to hospitals and patients, there is a significant cost to human health and healing. So, how do CLABSIs develop? There are two routes of exposure. Extraluminal infections typically occur within 7 days of insertion. The primary source of contamination of the catheter with bacteria or other microorganisms is the patient's skin. However, it is well documented that the hands of the healthcare worker are also sources for bacteria to stick to the lumen of the catheter and travel with the catheter through the epidermis into the blood vessel. Intraluminal infections occur when microorganisms directly enter the internal catheter during manipulation of the IV system, such as when accessing or connecting injection caps, tubing, or syringes to the catheter. Direct contamination from the patient's skin or own body fluids can occur. Less commonly, catheters become seeded from a secondary site of infection, such as a UTI or pneumonia. Rarely, contamination of IV fluids or medications can be the source of infection. Within minutes of the insertion of the catheter, the body reacts to the foreign body and damage to the endothelium. A fibrin layer forms, and pathogens interact with this layer to form a biofilm. Some pathogens break from the catheter and enter the bloodstream, leading to infection. The catheter and biofilm can also lead to a local infection, such as endocarditis. Once a biofilm is formed, the infection is very difficult to eradicate, since the pathogens are protected from antibiotic exposure. Bloodstream infections from contaminated central lines are largely preventable with the stringent use of evidence-based practices. Below I list several sites. They offer research projects, research results, evidence-based practice, and many times evidence-based practice is listed together in what's called care bundles, and we're going to talk about that in a minute. So, what role does the nurse play in preventing CLABSI? The nurse needs to assess her patients for the continued need for their central line. We all know how important hand hygiene is, even when we're in a hurry. If you're a nurse who is inserting central lines, it's important to wear full body covering, mask, cap, gown, and sterile gloves. Catheters are usually inserted into the subclavian, but it's less of a chance for mechanical damage, interruption, disruption to the catheter, and it's easier to keep clean. Many research studies have shown that chlorhexidine gluconate is a very effective skin cleanser. The femoral site is largely avoided. And there are many products new on the market, antimicrobial, antiseptic impregnated catheters, and chlorhexidine impregnated dressings. So if they're not available, if your facility can afford it, it's a good thing to mention. And I have a few more interventions that a nurse can use to prevent CLABSI, in addition to what we've just seen on the slides. One is educate other healthcare workers and peers in the care and insertion of central lines, and to not be afraid to speak up about non-adherence. Nurses need to use checklists diligently and follow care bundles. If one step is skipped, adherence is out the window for the entire care bundle. We need to advocate for the patient, ensuring those caring for them are adhering to best practice guidelines.
In 1996, I had a wonderful job, friends, and family. I was living life to the fullest and had just returned from a trip to Las Vegas where I went skydiving. Then one day I stepped off a curb and broke my ankle. I had surgery at a prominent Boston hospital and everything looked fine. I was expecting a full recovery within a few short weeks. But soon after, I needed a second surgery to increase the stability in my ankle. It was with this surgery that I got the Staphylococcus 3 infection. Because of lack of coordinated care, the Staph 3 infection escalated into a bone infection called osteomyelitis. This infection ate away 4 inches of my tibia fibula and half my ankle joint. Osteomyelitis is a fast-moving bone infection and is almost as difficult to eradicate as cancer. For the next 5 years, I endured 28 surgeries consisting of bone grafts, muscle grafts, and live bone transplants, and other painful surgeries. With each surgery, the physicians promised it would be the last. If the physicians initially treated the infection with antibiotics, the outcome could have been very different. The 27th surgery was going to be another excruciating live bone transplant. 2 days before the surgery, the infection reared its ugly self again, this time higher up on my shin. At this point, I was 105 pounds and unable to keep down food. I was a physical wreck. The infection and numerous surgeries had taken such a toll on me. This is when I decided amputation was the only way to save my life. 4 days after the initial amputation, I had to have another surgery because they failed to take enough off my leg. During this surgery, I went into respiratory failure yet again, a total of 3 times in the last 4 years. It was 5.5 years from when I broke my ankle before I took my first step, and it was on a prosthetic leg. A year from my first step, I had a brain aneurysm on my right optic blood vessel, brought on by the long-term infection in my body. I'm still alive and talking, but now without the vision in my right eye and some short-term memory problems. I've been very lucky to survive all of these medical procedures caused by the hospital-borne Staph 3 infection. I wonder every day what obstacle I will have to overcome. The staph infection did not ruin my life, but it has altered my life forever. Hospitals and physicians should provide coordinated care for all their patients throughout their treatment. Medical staff needs to follow strict surveillance, prevention, and reporting of hospital-borne infection. Had these practices been in place, the staph infection probably would not have occurred, and a broken ankle would not have resulted in an amputated leg. Remember, anyone can break an ankle, but that's where the story should end.